Well, good afternoon, ladies and gentlemen. Welcome to the Canon Medical System workshop. The subject will be the role of imaging in sports medicine. As many of you must know, Football Club Barcelona and Canon started a partnership in 2015 that was renewed in 2020 until 2025 after 5 years of a fruitful relationship. This partnership provides our medical services the possibility to use the latest innovations in the diagnosis imaging. We have 13 ultrasound systems, from portable to premium system, a last generation 3 Teslas MRI installed in 2021, and soon a digital radiological system that will be installed in summer 2022. Today, Dr. Sandra Mechó and Dr. Xavier Yanguas will tell us about the role of MRI and ultrasound in sports medicine. This session will be recorded and available soon in Canon Medical System YouTube channel. Welcome again, and thank you very much for your attendance. Sandra.
Thank you. Good afternoon. I'm Dr. Sandra Mechó, radiologist and a collaborator in the medical department of Football Club Barcelona. First of all, I would like to thank Gil Rodas and the organization committee in Canon Medical System for inviting me to do this presentation. I have divided in these 3 sections. The first one will be about the MRI sports pathology and the reason we prefer high-field scans. The second one will be about cases about sports injury best visualized by MRI, and in the last part we will talk about muscle injury. I don't know if you think that the MR has a very important role in the diagnosis of muscle injury, and I will show you. Until a couple of months ago, we were working with a Titan 3 Teslas Canon, and we've recently changed working with these Galan 3 Teslas. So all the images that I will show you in my presentation have been obtained with one of these scans. All of us are very familiar with Dr. Golano. He was a magnificent anatomist and also very good person and very good friend. And I once attended a course in which he participated, and he addressed radiologists thereby saying, "You are the future of anatomy, because the images that you obtain, you are able to see all the structures with much more detail and also with tension." And that's exactly what we want. We are made to be able to analyze detailed images of all the structures that can support a joint, for instance. And so that we may be able to detect, to identify developing injuries that could lead to a more severe injuries. And if we see these 2 images, they are from the same patient. The first one was obtained by a Titan 3 Teslas, and the second one was obtained a few months later to do the follow-up of his injury. The characteristics of these images are quite similar. They are of good quality. Maybe with the Galan 3 Teslas we have more contrast, okay? But pay attention in the time scan. There is a difference of 1.5 minutes. This is thanks to the artificial intelligence. As you know, the artificial intelligence is getting with high energy in the radiology world. And Canon has used it to obtain this high signal noise ratio image from this awful noisy image. And it's doing because we perform a neural network post-processing, and with this neural network we have this image with a short time, and after that we finally get this high quality image. Let's see 2 different post-processing examples. In the first one, we have used a filter to do a smoothing image. Personally, I think it's awful because we are losing information. Look, if we do a subtraction between these two images, we will see that there are some signal pixels that are disappearing. So we are losing information. Maybe one of these signal pixels is blood, is edema, is an injured. So we are losing this information. On the other hand, if we perform a deep learning reconstruction, if we use the artificial intelligence that I explained to you, and we do the subtraction between these two images, the raw image and the final image, you can see that there is no loss of any signal pixel. We are not losing information. So with this technology, we are able to obtain higher spatial resolution images in shorter time, in the time that we need to obtain this noisy image. This is a real example. This is a hip MRI. This is a proton density fat suppression coronal view of the hip. And look, we can draw the powdering of the labral and also the cartilage. And this image has been obtained from this image in just 3.5 minutes. It's fantastic. Now we will go to the second part. I will show you some specific cases of sports injuries. As I said, best visualized by MRI for sure. The first one is a rugby player, 29 years old, with pain in the posterior fossa of the knee, with a little bit of instability, and in the examination there was nothing. Largeman and pivot shift were negatives. In these three proton density fat suppressed images in the different planes, we see that some fibers, in fact the anteromedial fascicle of the ACL, are retracted, okay? Like in here, in this image. And we have fluid between the two fascicles, and also here we can see that there is a tear. This is a partial ACL rupture. Partial ACL ruptures are more frequent than we think, and we need to detect them correctly. And for that, we need sequences with double obliquity with respect to the ACL. So we usually obtain this coronal oblique with respect to the ACL and this axial oblique. In this coronal oblique, we can see this fluid and part of the anteromedial fascicle that has the fibers are retracted. And here we have the same. We can see that these fibers are ruptured. This is a soccer player, 26 years old, with patellar tendinopathy. And as you know, in 2019, during a symposium on tendinopathy, it was advised that we don't have to consider that any intratendinous signal pixel is tendinopathy. In fact, tendinopathy is a clinical concept, purely clinical concept, and the radiological findings should correlate with the clinical perspective. Signal changes without accompanying symptoms are tendinotic changes, what means adaptive or degenerative changes. If we have pain, if we have tendinopathy, the most important thing to say is not if there are signal changes, but whether the tendon has lost part of its structure due to a rupture. Here we have an example. We can see in these three images that we have a lot of granulation tissue in this tendon, in this proximal tendon. Inside this granulation tissue, there is a cavity. Okay, there is a cavity, but it's not enough. This cavity can be ganglia, can be synovitis, can be granulation tissue with a little bit more water, but we must to confirm that really is a rupture. And for that, we need sequences of such good quality as this sequence. This is a 3D where we can see the wavy pattern of fibers that are retracted. We can confirm, we are sure there is a rupture. In shoulder, there is a variant of Bankart lesions that is the perthes. It's frequent. And on the other hand, there are some situations that it's very difficult to identify. Why? Because the perthes is an avulsion of the anteroinferior labrum, but it remains in its normal position. So you will not see the labrum outside. So if you don't have images like this, you will not see this hyperintense line. It's separating the labrum with some fissures inside the labrum from the glena. This is a disinsertion of the labrum, and it's an instability for sure. In this second case, we will see an ulcer. It's a typical injury that everyone will see all these soft tissue structures that are together and displaced. It's easy, no worries. But what about the glad? Glad is when the arm is in external rotation, it's abducted, and there is a forced adduction. In that situation, we will find a fissure in the labrum and also an injury in the cartilage. But we usually don't have instability, just pain. The patient has pain, and you see this fissure, and if you extend distally, the fissure is here, separating the labrum from the glena, and finally we have here, there is an irregularity of the cartilage. The cartilage has to be gray, and here we have hyperintensity. There is also an injury in the cartilage. The growing pain is a challenge for radiologists, because as you know, in the pubic region, we have many of pathological MRI signs. As Dr. Kasarjan and Dr. Idoate show in this table that they filled in with all the signs that they found in different athletes in precision MR, what means asymptomatic athletes. In this study, they show that there is a high incidence of pathological signs in precision MR, but pay attention, we were talking about asymptomatic athletes. So are they really adaptive changes, pathological changes? For sure they are adaptive changes, but there are some exceptions. Sometimes you can see a sign that means alarm. As Dr. Childers points out, when you see a cleft, everyone knows what's a cleft. Cleft is the hyperintensity that separates the insertion of the adductor longus and its fibrocartilage to the periosteum. Sometimes this cleft extends to the lateral region, and in these cases, this insertion is at risk of injury. Here we have a case. This is a soccer player, 21 years old, that during a training in a snatch, he felt pain and loss of function. And we performed the MRI, where we see that there is a adductor longus, adductor minimum, and gracilis avulsion. Here we have the tendon, it's completely avulsed. But if we review the history of this patient, 9 months before, for the rectus femoris, we performed an MRI of the thigh. And if you see the pubic region of this patient, there was a cleft that it was extending to the lateral region. So in some situations, we think that we have to be more critical with the signs in the pubic region. In this case, the mistake was not analyzed in the correct way. And here we have the third part, the muscle injury. I can confirm that the MR has a very important role in the muscular injury diagnosis. Here we have three different cases. The first one is a soccer player, 23 years old, with a distal thigh soreness during a match. The sports medicine by ultrasound could see that there is a mild edema in the distal myofascial junction of the long head biceps femoris. But when we performed the MR, we could see the extension of this edema in the myofascial junction, and at this level, where the skin marker, there was a focus of more hyperintensity. Here we had a small gap of muscular fibers. If we see the coronal view, there is the same. This is the edema, and at this level here we have a gap. So that case is not a grade 2 according to the Xavi Valles classification. It's a grade 3, and in this situation the return to play was 3 weeks. In this second case, we can see that the MRI provides a global assessment of the region of concern, and it's very useful in the differential diagnosis. This is an indoor football player, 20 years old, with pain in the lateral of the thigh at the level of the vastus lateralis during weeks. The ultrasound was normal, and when we performed the MRI, in the coronal view, when you will see the skin marker, there is nothing here, but pay attention at this level. There is edema surrounding the proximal complex tendinous of the rectus femoris. If we go at this level by the axial view, we will see that this edema is because there is a rupture in the common tendon that extends distally by the central septum. We will go back to see it again. Here we have this longitudinal split, and this is the sagittal view. So that player who had pain in the lateral part of the thigh, the injury was in the proximal part of the rectus femoris. It was a very severe injury, and it took 10 weeks of return to play. And this is another case where I will show you that the global assessment of the MRI is very necessary. This is a basketball player, 25 years old, with calf pain during a match. In the ultrasound, there is a mild intermuscular fluid between the soleus and inner gastrocnemius. And let's see the MRI. We are going up. We will find here the intermuscular hematome between the soleus and the inner gastrocnemius. There is a mild edema in the posterior myofascial junction of the soleus, and finally, at the level of the skin marker, there is a rupture of the connective tissue. This is connective tissue that we can detect by MRI, so maybe it's not posterior myofascial junction, it's myoponeurotic. So the connective is important, it's thicker. This is for one hand, but for the other hand, there is a variant of normality, and it's very frequent to find variants of normality in the soleus. In fact, Dr. Valius and his colleagues have already talked about that. But take a look in this. Central septum is not central, it's lateralized, and the medial is long, and the lateral is very short. So maybe in these situations, the role of this connective tissue in the forces transmission is different. Maybe this connective tissue has a most important role. And it's because of that, maybe this injury took 8 weeks of return to play. If we talk about the advantages, the advanced technology that we are using surrounding the muscular injury or the muscular study, we are using the T2 mapping. The T2 mapping is based in measuring the increase in T2 relaxation time of muscle following exercise. In this publication, Carmona showed that when you activate some muscles, these muscles are more hyper-intense in the MRIs that we obtain post-exercise. But this is DP fat-saturated sequences. If we do the T2 mapping, we can measure the value. How much is increased this T2 mapping, this T2 value, okay? And the advantages of this technology is that we can study the muscle function during specific exercises or rehabilitation protocols. We can detect changes in activation patterns in patients with musculoskeletal disorders, and we can follow up the efficacy of interventions. When we perform a T2 mapping, we obtain these three different ways of information. This is a fusion, color fusion, with different ROIs, region of interest that we have drawn, like the ROI 10, okay? We have here the distribution of the different T2 values, but for me, the most important information is here, the database, where we find in the ROI 10, what is the T2 value, the average T2 value is this one. If we have this value in the pre-exercise, in the post-exercise, we will do the difference and we will see if there is an increase or not. We use it in this study with physiotherapists for a master's degree in Blackburn University, and they wanted to check which triceps uri component was activating with different exercises. And we can see that in the first exercise, the muscle most activated was the inner gastrocnemius. And in this exercise, it wasn't the soleus, it was the peroneus. So we could detect that in this case, the muscle most activated is the peroneus. So we have performed this study of the triceps uri recruitment. Maybe, I hope, we will restart the study of T2 mapping pre and post-soccer match, and maybe in the future we will be able to see what happened during a basketball match or a hockey match. Let's see. And finally, the last advanced technique that we use is the MRI-US fusion. It's a simultaneous viewing of the MRI and the real-time ultrasound, and it is very useful to improve the anatomical knowledge, to improve the understanding of injuries by ultrasound. It's an excellent teaching technique and an excellent follow-up tool, and it facilitates image-guided injections. Just the last slide, take-home messages. Among professional athletes, we need to be detailed, and for that we need high image quality. With the new technology, like deep learning reconstruction in case of Canon, we obtain images that are very detailed and with the same or less scan time. We need to ensure a fibrillar tendon rupture, a labral disinsertion without displacement, and be able to detect warning signs that may warn of possible future injuries. MRI is superior, for sure, to ultrasound in muscle injury in deep locations, lesions with refer pain, and in the study of variants of normality that may lead to a change in the prognosis of an injury. Functional T2 mapping MRI is being used to assess muscle activation according to different activities, and in daily life to assess abnormal muscle activation patterns. MRI-US fusion is still a technique in progress and could be important when assessing splits in connective tissue according to doctor values. And thank you for your attention. If you have any question, I will be happy to share some doubts.